Hey everyone, welcome to the fourth, count 'em, four sessions in our Connected Care in Action series, hosted by Canada Health Infoway and Longwoods. My name is Edwin Chacon, and I'll be your moderator for today. So today's session, accelerating together how public-private collaboration drives system change, focuses on a critical question. How can partnership between governments and innovators turn digital health progress into sustainable system-wide change? Across the globe, we're seeing what's possible when public and private partners move in sync. In the United States, the Trusted Exchange Framework and Common Agreement, or TEFCA, is establishing a nationwide public-private framework for health data exchange under the 21st Century Cures Act. It's simplifying how data moves by replacing dozens of one-off agreements with a single trusted framework. The result will be significantly reduced technical and workflow complexity and a foundation for nationwide interoperability, an effort expected to save the US health system over $77 billion annually through improved efficiency and data access. Here in Canada, that same potential exists. Al- um, Analysts suggest that achieving full interoperability across our health systems could save between 2.4 and $4 billion annually, and that's time and resources that could go directly back to patient care. What this shows is that progress doesn't come from technology alone. It comes from alignment. When governments, vendors, and clinicians share standards, design around real workflows, and build on a common foundation of trust and governance. That's exactly what today's conversation is about. How collaboration here at home is turning interoperability from aspiration into action. So please drop your questions in the chat and we'll get to as many as we can during the Q&A. But before we get too far, let's meet the leaders who will take us deeper into this conversation today. First up, Darek Szadkowski. Darek is the Vice President of Strategy, Programs, and Partnerships at Canada Health Infoway. He leads national digital health initiatives, including the Vendor Innovation Program, VIP, which you'll hear about later today, which is helping vendors align with standards and scale solutions across Canada. With more than 15 years in health tech, including Ontario Telemedicine Network, Derek's experience bridges product, vendors, clinicians, and patients. Next is Dr. Ashley Miller. Ashley is the Chief Medical Information Officer for Nova Scotia Health and IWK Health, and a practicing general internist. She's one of the leaders advancing one of Canada's boldest health system transformations, one person, one record, replacing more than 80 legacy systems with a single integrated platform. Ashley also participated in and helped shape the Digital Health Interoperability Task Force recommendation report, advocating for stronger vendor alignment and clinical leadership to accelerate interoperability. And finally, Dr. Mike Forseth. Mike is a family physician and a co-founder and CEO of Ava Industries. He and his partner, Dr. Matt Hensky, started Ava because they were frustrated with outdated EMRs. Their vision was simple yet ambitious to build a modern cloud-based system designed by clinicians for clinicians. What started in their Calgary clinic has grown into one of Canada's fastest growing EMR platforms, now used across Alberta and BC, managing millions of patient records. These are the leaders showing us what it takes to accelerate together, and I think they deserve a good round of applause for that. So let's begin by unpacking the challenge. Canadians' health information is still divided across a patchwork of systems spread over providers and regions. Clinicians face heavy documentation demands, and patients often struggle to access or share their own information. Promising pilots may stall before they scale, leaving vendors managing one-off integrations instead of building for the whole system. A recent study by researchers at the Toronto Metropolitan University and the University of Toronto found that achieving interoperability in primary care depends on cross-sector collaboration. Governments, vendors, and clinicians play distinct but complementary roles, and none can succeed without the others. The study described vendors as critical and central actors in interoperability, not just technology suppliers, but co-architects of the system. As the authors put it, their role cannot be understated, as their involvement is required in practically every process. So, Darek, you've worked across both policy and delivery sides of digital health. From your perspective, what's driving the fragmentation we still see across Canada's health systems? And how can stronger public-private collaboration help bridge those gaps and create the conditions for system-wide change?
Thanks, Edwin. We've started with a nice and light and easy question. Um, I think there's a lot of contributing challenges. I'm going to highlight a few of the ones I've seen over the past few years, but they're by no means the only ones. And a lot of the challenges that are driving fragmentation are unfortunately systemic in nature. If we take a look back and step back and think of our national landscape, we as Canadians believe and are proud, very proud of our healthcare system, but it's not a singular healthcare system. Healthcare delivery is driven by the local jurisdictions. So at minimum, we have 13 different healthcare systems in Canada. And that means that innovations that are successful in Ontario don't always scale easily to Alberta or Quebec, for that matter, or any other jurisdiction. And that's not only due to kind of the obvious language barrier reasons, but it could be due to regulatory changes in the different jurisdictions, or technical requirements that those jurisdictions have to play in their backyard, or how do they need vendors to integrate with their jurisdictional infrastructure. So that leads to kind of a natural fragmentation in the vendor ecosystem as vendors try to address those challenges. And if you look at the landscape, there are very few pan-Canadian, truly pan-Canadian vendors. There's vendors who have acquired a couple of subsidiaries that make them pan-Canadian, but vendor platforms are typically spanning a handful of jurisdictions. And so if you think about it, that problem is actually even more exacerbated in the EMR space, which we'll talk about here a little bit, in that if you have an innovative idea that you want to deliver to primary care clinicians, you're not just trying to integrate it with a handful of vendors, you're trying to integrate with a large number of vendors that have even differing product offerings depending on the jurisdiction that they're necessarily spending in. And frankly, our public sector procurement processes don't lend themselves to addressing this challenge. By definition, we're trying to find a good product that meets our requirements versus trying to actually procure something that meets the need and then can be adapted to suit. So these factors, amongst others, unfortunately contribute to a condition we call pilotitis, or why some call Canada the country of pilots. And that's why public-private collaboration is so important to try to bridge this gap and help products to scale. In some cases, standards can help clear the pathways between jurisdictions by bringing in consistent integration patterns, both into the local jurisdictional repositories and into point of care systems like EMRs, but they're just the starting point. Public sector has a role to play here, whether it's Infoway through programs like the VIP, which we'll talk about in a little bit to help innovations to scale, or through jurisdictions simply adopting those standards and being more aligned with each other. Regardless, in all cases, working collaboratively gets us there and be more effective faster.
That's interesting. Mike, you sit right at the intersection of technology and care as both a physician and a vendor. What is coordination across systems, many different systems, as Darek mentioned, and teams look like in your daily work? Where do you see it functioning well, and where do gaps still get in the way of delivering care or scaling innovation?
Well, definitely what he just said is very true about community practice being quite separated from large hospital systems or big providers. And that was our experience when we started AVA. So much of the medical system still runs on fax machines, and a lot of people in the room, maybe including you, Edwin, have probably never even seen a fax machine. We have new people that join our company all the time who don't know what it is, but literally everything that comes in and out of our clinic in the community goes by fax. And it's a great example of barriers to good communication. It's representative of the amount of time we spend on paperwork too. So every doctor in every clinic is spending a lot of time just receiving paperwork, pulling information out of it, trying to restructure it, and then organizing it back into something that goes by an analog fax and sending it to someone else. So there's huge opportunity to fix all those problems in the system. And it does require big solutions from national leaders to really replace something like a fax machine, as an example. Every clinic uses it, so you can't just have one innovative clinic moving to a new form of communication. Lots of people have tried it, and it just doesn't get solved that way. We also just need to figure out ways to meet patients where they need care. I think, if you think of how a patient comes into the system, they come to community practices or primary care practices, and there's a lot of steps to basically get them all the way through to the place where they get care, and all of that is transmitted digitally or through fax right now. So streamlining that as much as possible would be valuable. And I'll give you a few examples of what we've been able to do in our practice to try and coordinate across those systems. So, part of it was we built Ava for that purpose. We wanted to bring patients into a digital space with us so that they could communicate directly with their clinics and with their doctors, not just come in for a single visit to get a piece of paperwork that could have been done remotely and saved everyone a bunch of time. And we work with a great partner in Alberta called Alethea, which is also a private company that connects us directly with specialists across the province, so we can get simple answers to questions without formally referring a patient into the hospital where they might wait 6 to 12 months to get a simple answer or get the next step in care. So we've really seen that on the ground, that a well-integrated digital system can really streamline the patient experience, which is really helpful for them. This is all about getting patients faster care and answering their questions quicker. We're competing with Google, and now we're competing with ChatGPT, right? So we need to be in that space with patients to support them. And some really exciting new examples that we're working on. So we're doing a digital lab integration in Alberta with the government. Ava got the opportunity to build the beta for that, and that's going to allow doctors on systems to order from the community labs rather than giving patients little pieces of paper to carry around with them to go get their labs done. And of course, Infoway has funded some projects for us, including the VIP project, which I'm sure we'll go into in a bit more detail later. But all of that helps small players who I think, like us, have really great front-end solutions that users love. It allows us to integrate and play in a bigger system.
Ashley, Mike mentioned a lot of issues, one of them being fragmentation, which I know Nova Scotia has been tackling head on through modernization efforts. Can you paint a picture of what things look like for clinicians now, and what current modernization efforts are hoping to achieve for government providers and vendors?
Yeah, thanks so much for that, Edwin. Nova Scotia is at a tipping point. So we've done all of this extraordinary work around modernization, but it has not yet translated to meaningful change on the front line. So as a general internist in my academic tertiary care hospital, I still write on paper. So if I saw you in the emergency department, I would write my orders on paper. I'm doing a chart review of a system that is basically a digital filing cabinet. So it's filed pieces of paper that are scanned. It's not searchable. So if I'm looking for my endocrinology colleague's note, I'm on page 200 of a 500-page scanned document at times. So very, very antiquated system in terms of what we're dealing with on a day-to-day basis. But that's juxtaposed against this massive effort to actually digitize and modernize our healthcare system within Nova Scotia. So there's two main frames of work. So one is just the digitization of our clinical workflow. I'm going to talk about one person, one record later on, but basically implementing modern clinical information systems. But the other massive amount of work that's not owned by me, it's my colleagues in the CIO shop, is around data standardization and looking at how do we actually standardize the language of data, how do we apply FHIR standards, and how do we leverage that in order to improve access to data. And that actually has translated to very meaningful change for patients who now have access to an EHR, which is excellent. It's called Your Health NS. It's an app-based repository for data, and they're limited by what's available in current state because we're not yet at the digitization maturity that we could be, but patients are now accessing their labs, their appointment data, diagnostic imaging data. So there has already been a democratization and an empowerment of patients through application of data standards, which has translated to real meaningful change. And we have a lot in the pipeline. Our first go live for OPOR is just 40 days out. So we're on the precipice of really transforming the experience of our frontline providers in Nova Scotia.
Oh, that's great to hear, and congratulations. 40 days out. It must be a little bit nerve-wracking, but I'm sure that I think everything will go well. So what I'm hearing is that there's a system, we have a system that's full of information, but there's still a lot of silos. But the good news is that we're already seeing what's possible when governments, vendors, and clinicians work in sync to bring those pieces together. So let's take a look at when public and private partners come to get together to deliver real progress with an example from our own backyard. Infoway's Vendor Innovation Program, VIP, which I think is a great name, brings public and private partners together to align solutions with national standards and scale. It's designed to showcase how innovation can accelerate the adoption of interoperability by improving data quality, enhancing care coordination, and expanding access to standardized, actionable health information for patients and clinicians. These partnerships show that when sectors collaborate with purpose, local innovation scales faster, patients' care becomes more connected, and Canada's health system grows stronger for everyone. So, Derek, walk us through the vision behind the Vendor Innovation Program. Why was it created? What makes it different? And how does it show the role of partnerships in scaling innovation nationally?
Thanks. The Vendor Innovation, or VIP, and we're all very important persons in this. Apologies for that poor acronym. But it's merely meant to recognize that partnership between public and private sector is really critical in addressing some of the challenges that we've discussed and we're facing. And the role of public investment to accelerate private innovation in a manner that's aligned with public sector priorities. So if you take a step back, the context behind the VIP is that Infoway is all about creating standards and making sure that the data that is exchanged between systems is standardized using a known format. But we also acknowledge that there's a huge step between standards and actual interoperability. And the step before that is adoption of these standards, and the step before that, there's many steps and many challenges along the way. So the Vendor Innovation Program is meant to recognize that public sector cannot solve these challenges by itself, and was meant to invite vendors to actually help us solve some of those challenges and make those things a reality faster than they otherwise would have been. So we asked vendors to submit innovative ideas, like you said, in addressing challenges to scaling patient summary was one of the focus areas, improving care coordination and collaboration, or using emerging technologies like AI to alleviate administrative burden. And there were several things that were really important for us when we crafted the VIP. One thing from the get-go was that we needed vendors to showcase and prove their innovations, so to speak. So we created every requirement that every project needed to have a demonstration period from the get-go. And the second was that demonstration plan would need to be created with the awareness of and alignment of the jurisdiction in which this demonstration project was to take place. And in many cases, those jurisdictions jumped in and collaborated and helped co-design those demonstration periods and those demonstration projects. And finally, vendors are required to submit a report at the end that will showcase not only what they did, but how was it successful? If they used AI, what kind of metrics did they come out with? And what lessons learned, most importantly, did they have going forward? So that means at the end of this, hopefully we'll have a set of projects that not only address the challenges we're facing by pushing the boundaries in innovation and AI, but we'll know what works and what doesn't, and we'll be able to leverage that knowledge going forward. And then if you think of it in terms of scaling, the VIP actually gives vendors hopefully a little bit of a proving ground that they can leverage then in more traditional procurement processes, and also a platform, because we're trying to shine a real spotlight on these projects from a national level, and inviting our jurisdictional partners to view and showcase these projects as they evolve, and to understand what the results are as they go forward.
Thanks, Derek. It really is such a cool program that highlights how national coordination can turn innovation into impact. Ashley, you were part of the DHI task force, whose 2024 report identified vendor mobilization as one of the key enablers of progress. From that lens, what stood out to you about how vendors, governments, and clinicians can best collaborate to improve data access and exchange on the front lines of care?
Yeah. So I think that foundational work I talked about around data standardization is so critical because our vendors, to Mike's point, navigate this complex environment where even to have a client in different provinces, you have to speak a completely different language, have a different lexicon of data feeds. So that complexity actually limits vendors. Like I know so many clinicians who are at the interfaces as Dr. Forseth and colleagues who have amazing ideas but can't navigate the complexity. Like they're clinicians on the front line who see problems, who have solutions. But to imagine being a vendor, to have to navigate this environment where every province has different data standards, different privacy legislation, just a massive environment of complexity, it makes it very, very difficult to be a new entrant, which is why we see these sort of digital monopolies where even though vendors don't necessarily have the solutions we need or their user interface, I can't help but preemptively look at the chat, but there was a question about workflows actually being hampered by digitization. I think that is a product of not adequate competition in an environment where there's so much complexity as a new entrant that it's very difficult to navigate that. I think a lot of solutions will come as we move towards data standardization and the kinds of standards that we advocated on the task force. But I think also just as vendors increasingly have access to information in a different way, especially leveraging artificial intelligence to help navigate these processes, I think we're going to see new entrants, and that's going to level the playing field a little bit. But I think fundamentally what we tried to speak to in the task force is this concept that we have to fundamentally revisit vendors, not as vendors, but as partners in the healthcare system, because the pace of change that is occurring, like even within my own clinical practice, I'm not that long in clinical practice. And I would say most of what I learned in medical school is not really that relevant anymore. And definitely within my specialty, I'm a house doctor as a general internal medicine doctor. It would be crazy to trust my learned memory of rare diseases versus going to ChatGPT. So just the whole function as clinicians that we serve has radically evolved, even in a very short period of time. And I think we have to revisit that vendors really are a critical equation in that relationship for delivery of digital solutions. And I think the focus we had from a clinician perspective was very much about empowering vendors to understand the local context, because although we're very similar, we're also very different. And, we have lots of data in the EHR implementation space specifically that you can have same product, same deployment, same vendor, and radically different results across different jurisdictions. And that relates to that context piece, that clinical workflow piece, engagement, leadership attitudes towards digitization. So I think there's so much opportunity within Canada, but I'm hopeful that standardization will actually improve the competitive nature of our vendor space, because hopefully the complexity will go down, although maybe we've yet to see that delivered.
No, I completely agree. Like it really sounds like, vendors are an important part of this equation, right? Mike, you and Dr. Hensky started Ava out of a Calgary clinic, and today it's one of Canada's fastest growing EMRs, serving hundreds of clinics and millions of patients. You're also part of the 2025 VIP winning cohort. Can you walk us through the journey of how Ava grew from a single clinic to a national solution, and how VIP is helping you scale while aligning with, national standards and public sector priorities?
Well, first off, I'd say Ashley nailed it, and that when Matt and I started, we were a little bit naive, I think, which is it's very hard for new tech products to show up in this space. There's immense barriers to entry around privacy. They're legislative, and they're also just finding clinics that will trust a new system to come in and manage health data, which is obviously very sensitive. So yeah, you have to be a little dumb to enter this space. And luckily, we're really dumb, and we tried very hard. But we were very focused on a vision. And I think part of our success has been that we are physicians ourselves, and we feel like we really understand what we're building. I really like to highlight that we build a lot of systems that on the structure level make a lot of sense, but for the end user don't always work very well. And actually, that's the big failure of EMRs over the years, is that we turned doctors into data entry people rather than letting them focus on patient care. But yeah, Matt and I started, we just didn't like the systems we were on. We started sitting at coffee shops and picking high level concepts for what we wanted to build. And we ground it out over years. We built our own system, and we kind of focused on 3 core things. We wanted to link all charts together so that we didn't have to search around different data silos to get data. Actually, the original version of AVA was the concept was a shared record, but legislation doesn't really support that. You have to keep data somewhat in silos in community practices, which we'd love to fix eventually. We built it from the ground up as a patient engagement platform where patients could connect directly with their clinics, share all their data, book their own appointments, message back and forth with different providers. And then the third one was we really wanted to solve the data entry issue, which was 10, 20 clicks to get a simple task done. So we set a vision for doing 90% of our work from 2 screens and 2 clicks. We don't always get there with all workflows because sometimes there's a lot of data entry still, but we are vastly faster than most of the legacy systems. And that was really well received. Actually, when we started, we had almost no integrations to some of the government systems. But customers signed up anyway, because I think they really want that experience on the front end for them and their patients. And then the integrations have come later once we've proved our value and proved that we could scale the product. But I would love to see those opportunities earlier. And I think that's where grant funding and national support really comes in.
It's really great to hear your story. It's a very inspiring Canadian story about how we can work together and create products that really, at the end of the day, supports clinicians and patients. Ashley, you're seeing a similar story play out in Nova Scotia through One Person, One Record, which is one of the most ambitious digital health transformations in the country. Tell us a bit about OPER and what partnerships are needed for something like OPER to succeed. How does this connect to the broader national effort that we've been discussing today?
Yeah, so just to bring us back to that sort of vision of me as an academic general internist in the emergency department, looking at my digital filing cabinet and writing my orders on paper. There was this vision. It's, the thing doctors tell me in Nova Scotia is I'll believe it when I see it, because we've been talking about this vision of one person, one record for like a decade or more, from long before I started as an attending. But the vision was fundamentally just that one person, one record, that you had this longitudinal record that transcended community care settings and that enabled clinicians and patients ultimately to have control of data in a way that supported optimal clinical care. I would say, we focus very much on the acute care environment to start with. It's a hospital-based system fundamentally. So our vendor is Oracle. It's PowerChart that we're implementing, and our implementation partner is Accenture. And we're focused on everything that occurs in the hospital environment. So it's not just acute care in terms of emergency department, ICUs, inpatient wards, but it's also the clinics within the hospitals, operating rooms. So it's a very full scope clinical information system. And it's analogous to what was done in Alberta with Connect Care, where it's not institutional based or even regionally based. It's really a robust provincial system. So we've already finished the design phase and we're implementing a provincial design. So we went through a lot of forced standardization through the process of design, because you can imagine, even though we've been a single health authority now for over a decade in Nova Scotia, there's lots of practice variation, even within zones, institution-based practice variation. So this design of a clinical information system has actually forced a lot of clinical standardization work. But what we're applying is a provincial solution. And it's fundamentally a clinical information system intended with that frontline clinical perspective. So integration with, for example, bedside devices used by nurses, so that rather than having to transcribe vitals from, I joke today, it's in a post-it in the pocket of the scrubs, getting manually transcribed at shift change, and obviously the physician having limited access to that data to make clinical decisions, that's translating into a modernized environment where the machine is auto-populating the record and it's real-time access to longitudinal data. In the Nova Scotia context, that's really important because we have lots of mobility within the province. I work in the academic tertiary care center where we have lots of patients come from other places within Nova Scotia, but that's not comprehensive enough. We also have lots of people come from Prince Edward Island and New Brunswick, and in current state, the scope does not include those records. So there's still a critical need for interoperability beyond even the scope of this program. And then the other big gap is the community-based records. So I had mentioned there's other work around data standardization and actually building a FHIR repository in Nova Scotia. And that's where we're going to see the rubber hit the road in terms of that more longitudinal record. I didn't mention this in my opening, but we're a lucky province in that we only have 2 approved EMR vendors in the primary care space. And our CIO actually recently joked to me that he was very excited about that when he started, but then you realize even though it's 2 vendors, there's thousands of different instances and there's no standardization. So what one clinic constitutes as a visit type is not the same as another clinic. So it's very difficult, even in the context of a limited vendor environment, to actually drive that kind of standardization. So there's a lot of work happening now to how do we get to a point where those data feeds are standardized to a point that we can actually meaningfully integrate with the hospital-based systems, that we can realize that true vision of one person, one record. And I mean, I think I've again noticing questions in the chat about the process of change management, and we've had infinite learnings over the process of implementing this system. We're doing phased rollouts by zone. So starting with our Pediatric and Women's Health Center, IWK in Halifax, the go live is December 6th, though stay with bated breath with us, but intended to sequentially roll out across the province to finish the project hopefully by end of 2026. So just an immense learning, but I think a major learning we've had is that it really doesn't matter the platform or the vendor. What matters is that standardization, that application of a shared vision, application of shared standards, understanding what the benefits realization is, because there is a lot of pain that will come. I mean, I feel like I'm starting really at the baseline where anything has to be better than having access to very limited information, but I have clinical partners in the system who have pretty functional solutions. So for us to ask them to transition and to take a leap for the greater good has come with lots of challenges. And I think we've learned a lot about how to manage change in a complex system.
Yeah, at the end of the day, that complex system it really requires collaboration. And what I love about today's conversation, I think each one of you have really shown how important collaboration is and how it plays such a key role in driving real progress across the country. But we know that lasting change depends more on more than just a good project. It depends on strong partnerships. So the question then is like, what makes these partnerships succeed and last? Darek, you've seen how public-private partnerships take shape nationally through Infoway's programs. What factors or conditions help alignment between governments, vendors, and clinicians take hold?
I think I'm going to wind up building on quite robustly on what Ashley and Mike have brought to the table, because I think one of the biggest factors is alignment on priorities, and also alignment, making sure that value accrues to everyone in the system, vendors, clinicians, and the public sector. Right. So we've heard a lot about change management and the challenges that occurred beforehand. If we can, focus a little bit on that clinician stakeholder group as the last one, and very important one, if we can align and make sure that there's value to clinicians, we see a tremendous amount of success. One example that we can bring to the table recently is the AI Scribe program that Infoway recently launched. And I know that's the focus of today's sessions, but it really serves as a great example of how quickly we can onboard clinicians and what level of interest there is if we can fix some fundamental problems. And wow, was that an amazing achievement. Fastest adopted program by Infoway by a mile. And really goes to show if we can derive and drive value to clinicians, they're ready, they're willing, and they're interested. So I think that's one aspect that I think is fundamental. I think another aspect is to make sure we're building on strong foundations, and we talked a lot about standardization of data, and the Pan-Canadian standards that Infoway's been collaborating with everyone on are an important aspect of that. These can help alleviate some of the barriers we talked about intra-jurisdictional. They're not going to alleviate all of the barriers, but help create some confidence in the vendor community to be able to start to scale across the country. We're at the beginnings of that journey, but the vision is clear to enable that broader interoperability and also fluidity between jurisdictions. And finally, I think this builds on the first point, but it's about building alignment and understanding between and that partnership that you mentioned, Edwin, and creating the opportunity for public and private sector to listen and build trust. And Infoway's role as a convener here is evidenced through initiatives like the Industry Collaborative, the Interoperability Industry Collaborative, which is a collaborative of vendor stakeholders, but frequently meets with jurisdictional executives, and is critical to fostering that open dialogue. The industry charter that we've published in the last year or so is a collaborative work on is an important step and foundational step in that aspect. So I don't think there's a silver bullet here. I think it's a multifaceted approach that recognizes that everybody has a stake in the game and everybody's role and should be recognized and should have value as the projects move forward.
I wish it was a silver bullet, but it really ends up being like that collaboration, that discussion, and that alignment of priorities play a big role, right? Mike, you've experienced partnerships from both sides in the clinic and as a vendor. Where do you see partnerships thriving, and what makes a collaboration work at a practical level day to day?
Well, I'm going to end up just expanding on what Darek said or adding to it, but I think common vision is really important, and I think it's always vital to keep the end user experience in mind, and obviously the fact that we're all trying to improve patient care in this, right? So the patient is really the start user of all these systems. And so, it's obviously a large system design problem to try and integrate all these data points and achieve interoperability, but you still need an entry point that physicians, nurses, MOAs, staff at clinics, and patients can easily interact with and doesn't add to the burden of the system overall. And that's, I'll go to Darek's AI scribe point. I mean, I think we saw with that a lot of clinics being very interested in using AI tools quite quickly because they thought they would be highly impactful. What we heard from a lot of our customers around the AV ecosystem was a lot of concerns, though, about privacy and how they should, what systems they should buy and whether they could trust them and what their obligations were. And I think Infoway supporting those kind of things and really clarifying for users how to behave and what they could purchase or that there was a national body supporting it really helped them move quickly with confidence, but also choose a product that they liked in the private space rather than just being given something that was designed for them by someone else. So I love to see those kind of partnerships that can move quick and be agile that way, because the tech space in Canada is really far behind. And I think it's a legacy of maybe a little bit too much regulation and not fast movement and not the right funding at the right places. And I do see it suddenly accelerating with these kind of approaches. So
I think you really hit the nail on the head that, part of the problem is that we have a system design issue that's going to need quick and agile partnerships to really make progress and address some of these problems. Ashley, as both a health system leader and practicing physician, you're helping lead one of the country's largest transformations in Nova Scotia. What's been key to making partnerships of that scale succeed? How has clinical informatics helped turn that vision into practical transformation for clinicians in their daily work?
Yeah, so I think what's made for my favorite vendor experiences in the CMIO role has been this dogged focus on user interface and specifically clinical workflow. I'll call out a specific partner because it was such an exceptional experience. Ocean managed our e-referral system within Nova Scotia, which the original scope was very perioperative and diagnostic imaging with intention as the CIS comes on board to kind of expand. But they were relentless in their willingness to lean into the pain points. And I think about it from a scalability perspective. I can't speak for Ocean. I don't know if anyone of them are on the line, but like that's a lot of effort invested that's not necessarily transferable in the absence of a standardized data infrastructure within Canada. Because a lot of what they were doing was very contextualized to our environment. So, if you can imagine overlaying that dogged obsession with our pain points and, their willingness to continually come back to the table and deal with some, outspoken physicians, that could have been a massive boon for everyone in the country if we had sort of this shared data standards where those iterative changes that they've made in our context could actually be applicable. But that's not really the case, right? It's so individualized in our current standards environment or the absence of standards, that I can appreciate that that's actually really difficult work for a vendor to do. So I think that was an exceptional experience, just kind of based on the vendor themselves. But I think that dogged obsession with my workflow is really what I'm looking for. So intellectual curiosity about how do things work. And I think we've all spoken to this, that it's not enough to just apply a solution, because although the problems may be shared and the vision may be shared, sometimes how you have to apply that solution, like even roles, Nova Scotia's in our infancy in terms of physician assistants as a role within the system. So you can imagine that vendors who have honed solutions in other spaces for that role would have to adapt in our context. So I think there's always going to be that customization. And I think when it's driven by an understanding of what problem you're trying to solve for me as your end user, and as granular as a few clicks, like I couldn't believe with the e-referral experience how obsessive doctors were about this can't be one extra click. What seemed sort of irrelevant to me, maybe as I'm more tech savvy or someone who was in a generation where my ability to navigate a system is pretty strong. For some physicians, that was a make or break. Like those extra clicks were sort of enough to feel that they'd lost confidence in a system that they believed the vision of. Like there was no lack of alignment on the shared goal of that e-referral system. There was a huge recognition of the value proposition, but there was a feeling that it can't come at the expense of my ability to get through my day. It can't be another administrative burden. So I think Darek summarized it perfectly in terms of the uptake of the AI Scribe. Like if you design a good system that solves a problem for me, it's really a non-issue, but we have to think about how do we create a data environment and how do we leverage standards so that the work that you're doing to solve that problem for me is actually also going to solve a problem for Mike and our colleagues somewhere else in another jurisdiction. And I'm not sure we've gotten there yet. And, that's the perpetual country of pilots. It's actually difficult to emerge from that country of pilot model when we don't have a shared understanding of what we're aiming towards in terms of data standards, because it's always going to be this bespoke customization approach rather than being able to leverage those learnings of customization to other jurisdictions.
Yeah, no, I think what I'm hearing is like workflow, and I've heard this conversation or this piece time and time again in private conversations and in these panels. Like this workflow piece is such a critical thing to get right in order to actually move the yardstick. And standards is an important part of that. And recent conversations have brought up AI and talking about AI and how can AI play a role. Actually, from a clinician's lens, how do you see AI shaping the future of these collaborations? Like, what will it take to ensure that local clinical innovation, the kind that starts in individual practices or health teams, can scale responsibly and sustainably across health systems?
Mm-hmm. So, I've long had this feeling that we're going to hit a tipping point in consumer culture where we're not going to accept what we have in the current healthcare environment. And to some extent, I already feel that, if my bank can validate all of my financial information on my phone, like why is healthcare so different? Why are we so obsessed that somebody might be able to see my CBC or ferritin? I think we've been marred by this sort of antiquated understanding of our conceptions of privacy, of digitization within society. And I think AI is going to blow us out of the water because, as Mike said, we're not competing with Google anymore. We're competing with ChatGPT. Like the pace of change of expectations of consumers in this country will outpace our capacity to do it alone within the public healthcare system. I believe that. So we're going to have to leverage partnerships because our ability to be nimble enough to adapt to that shift in consumer expectations will not be fast enough. And I think conventionally we've kind of thought about patient as the consumer, but I think very much it's increasingly going to be the clinician. Like if I can you leverage tools that are free and readily available to summarize data, to synthesize evidence, to gather the newest information, why on earth as a clinician would I not be leveraging those tools? Like why would I be going back to a manual process where I'm having to sift through paper documents, or I'm having to synthesize information or go back to a guideline rather than being cued to what I'm missing? Like I think we will have this push from clinicians that it's not good enough anymore, because I think the experience many of us have as clinicians is we're going to those tools to support our clinical practice. And there's a significant danger in that. I mean, obviously we have training on how to minimize PHI being shared and that sort of thing. But I think if we don't have the capacity to integrate those workflow, that into our clinical workflow, then we're risking that consumers are just going to go elsewhere, like clinicians are going to go elsewhere. And then it's very difficult to control data standards or to ensure privacy or to ensure that, you know, we're applying the best vendors and making sure that there's rigor in terms of evidence review or ensuring that algorithms are reasonable for a clinical context. So I very much see AI as a driver of shifting expectations as consumers, both from a patient and a clinician perspective. I do still find that workflow piece so critical. You know, I think the team at Signal One may have been where I heard this, but there was this, you know, pilot of a algorithm in one setting and it had incredible results and they deployed in another and it was like not reproduced at all. And it wasn't because the technology wasn't the same. It wasn't because sepsis isn't the same in every clinical environment. It was because of those contextual factors of how clinicians receive information, their sense of trust in a solution, how that incorporated into, for example, if you're doing early warning systems, my hospital doesn't have a rapid response team. So what do you do with that information when it's flagged? Like there's so many contextual factors that determine the utility of AI solutions. So I think we need to, again, sort of apply those same first principles around understanding of workflow and providing vendors with standard expectations so that the work they're doing in one environment can be scaled and then contextualized versus having to build from scratch every time they go to a new care setting.
I know we're running out of time, but Derek, I wanted to quickly check with you, like, how can we build from that from like a national perspective? You know, Infoway's VIP program, we're seeing a growing number of industry partners developing AI-enabled solutions from across the board. How do you see partners leveraging AI to accelerate responsible innovation and advance Canada's broader goals for connected care?
That's a really good question, and we're really thrilled to see that a lot of the VIP applicants and most of the recipients are leveraging AI in some way. And I think I want to hone in on the responsible part because I think that's the bit that I think is critical here. And I think AI has tremendous opportunity to accelerate interoperability in a responsible manner, whether it's just through automating processes or making sense of the vast swaths of data that's available. So, you know, I'm going to leverage an example that's one step further, or one step more modern than Ashley's example, which is even if you have data in a digitized format and you have a complex patient, and if you just try just as a mental example to print all that data out, you're going to go right back to the 200 pages or an inch thick binder. Sure, it's there in a digital format, but if we start thinking of enabling interoperability and sharing that data back and forth, you know, if it's not meaningful, we're not going to make a tangible impact on that patient's healthcare outcomes. So we're really focusing on meaningful data information sharing, and I think AI has the potential to help us make sense of that vast swaths of data, which is kind of what it's built for. Have it reviewed by a clinician, make sure that it's right, and then have it be shared as kind of one model that we're looking at. So VIP has looked at some of those models in terms of automating the analysis of vast swaths of data and then turning it into standards-based, FHIR-based patient summaries, for example. Whether that's looking at a patient chart before a patient shows up and saying, tell me what changed since the last time the patient has been here, to generating that patient summary that I just described, or even as Mike alluded to sharing that patient summary then later with that patient so that they have it on hand. And we've talked about AI Scribe, and I know we're running out of time, so I won't go back there. But you know, through the VIP, we've also seen applications of how we can extend AI Scribes not just between in clinic, but also to other healthcare workers and into the patient's home. We think about home healthcare visits and or assessment visits for occupational therapy. Those are some interesting applications for that tool. And finally, we're investigating where we can use AI to automate processes in healthcare. One area is quality of care audits. These are audits that are currently conducted by high-skilled workers, in some cases nurses. And if we can automate that, and again, going back to the responsible manner, then we can all of a sudden free up those highly skilled, highly valuable resources and deploy them elsewhere where they're desperately needed. So those are the kinds of applications where we're seeing AI and accelerate innovation, and also advance just our general goals for connected care. I want to acknowledge that there's a lot more to be done and learned, and I think going back to the aspect of responsible use is the one that we're going for.
Yeah, and it really sounds like, you know, a lot of these successful instances of leveraging AI really pay attention and take into consideration that workflow piece, right? Like Ashley was mentioning, there are so many important things to consider and how we can leverage this new technology and advancing the mission forward. Mike, as a VIP award recipient yourself and an early leader in integrating AI within healthcare solutions, how is AI helping your organization grow, scale, deliver better experiences for clinicians and patients? What have you found most important to consider as AI continues to scale across Canada's health systems?
Yeah, so we were actually lucky to have Matt Henschke on our team, who's really led so much of our technical development, and he saw the early opportunity for AI. And I think we had probably one of the earliest AI scribes in Canada in 2023 launched directly within our system. And it instantly convinced me of where things are going to go. I immediately saw this opportunity to do an hour less typing every day just from the AI scribe documenting my visits. And it's since changed into an opportunity that can do so much in the system. I talk a lot in our company about data in, data out. We're really trying to pull structured and unstructured data into the system and then hopefully send mostly structured data out to other systems. And the structured part requires integrations, but I think you're going to see AI be really good at bridging a gap where you can receive a very big unstructured data set, like the 200-page document Ashley talked about earlier. And AI can do a pretty good job of pulling structured data out of that document and populating the record for me or taking me to the right page where those data elements exist. And in a way, that's what we're trying to do is structure everything so that I get a high level summary and I can read it and exchange it with other people. So we have a beta tool in our system already that does that. It goes through documents and pulls things out, and I can just single click to populate the patient chart, which is really, I mean, it's fun. I kind of laugh out loud sometimes when I see these changes because it really does solve a problem that a lot of users have. I think as we see AI grow, I'll just echo a few things that have come up already. Privacy is really important. And like Ashley said, it sometimes hampers patient care if we lock things down in silos and we're too private. But also, a lot of these models, we have to make sure we know where they're being hosted and how the data is being used long term. We really want to protect Canadian patient data from inappropriate use. And I think it's important as well to remember that the current conversation around AI is largely large language models, which is like a really exciting autocomplete function. It just writes a whole paragraph rather than the next two words. But there's going to be limits to that, and I think the great thing is it's going to solve a text handling problem for a lot of physicians or healthcare users. But it's not the oracle of health that gets things wrong. I tell a lot of people, you have to treat your AI like you treat your medical intern or your medical resident. They say things that are mostly right most of the time, but your ultimate job is to be the decision maker. We're not ready to let these tools make broader decisions for us. Healthcare providers are still immensely valuable within the system in patient communication and care coordination. But they should all those healthcare providers should be trying to learn about AI tools and use them because they're high impact.
Great. Thank you so much. So it's, honestly, hearing from all of you today, I gotta say, the future's bright. We have a lot of smart people, not only here on the panel, but also here in the audience that have a lot of great thoughts and great ideas, and I really appreciate it. I want to take some time to get to, hopefully at least one or two questions today that we've seen come through the chat. And while we don't have time to answer every question, we've tried to prioritize the ones that have been asked the most frequently. So to start, quite a few audience members here want to understand how we balance clinician workflow when introducing new tools, specifically helping reduce their burden versus adding to it. And I think based off our conversation today, you've all answered this in one way or another. But perhaps you can provide your number one recommendation to ensure innovations are introduced with clinician workflow in mind. Ashley, maybe we can start with you, and then we'll go to Mike and Darek. If we have anything to add and we have time, we'll go to you.
Yeah, I mean, I think there is a reality that we all learn these shortcuts, right? Like we MacGyver our clinics in a way that tries to minimize the administrative burden. And sometimes in introducing novel digital solutions or even data standards, we are pushing clinicians to do something different. And, Mike made the point about we don't want clinicians to be data entry tools. We don't want that to be a function. And I think that's where AI provides a lot of opportunities, is how do you listen to what I'm saying and actually pull out that discrete data so that I don't have to later retrospectively enter it, but you've kind of captured it. So I think there's technology levers that can help alleviate that. But I think there is a reality that, sometimes it is a bit more work. We talked a lot about in the interoperability task force as physicians that, we don't document for the purpose of populating a record. Like, we document for the purpose of when we come back to see that patient again, we remember what we did last time, and we document for the purpose of communicating with our care teams. But in reality, there is a huge other function as clinicians that we have to be privy to, which is documenting for the sake of populating that care continuum, understanding system requirements, driving public health interventions. And I think that's a difficult one for us to accept, because it's not necessarily our obligation to the patient in front of us, but it is part of our broader obligation to serving a healthcare system. So I think there are opportunities as a vendor, working with vendors, to actually work on the click fatigue, like to find user interface opportunities, find integration opportunities that make those workflows better. But I think it's also getting clinician buy-in to understand that incremental increase in effort actually does translate to very transformative care from a system perspective. So a lot of what I do is try to conceptualize the digitization efforts we're doing, not so much from the perspective of like, then we'll all know what the vitals are, but then we have the ability to do quality improvement, to do continuous practice audit. Like, if I want to ascertain some kind of information about the clinical care I provide in current state, I have to do a manual chart audit. Like, that doesn't allow me to function as a learning clinician in a learning healthcare system. So there's all of these side effects that come with digitization that I think providers are deeply committed to. We all want to provide the best quality care to our patients. We all want a healthcare system that promotes health and wellness. We all want to minimize errors. And I think in order to do so, we have to start shifting our perspective, not from data for the perspective of, government having insight into what I'm doing, but from the perspective of us being able to function as a team-based care system to deliver the highest quality of care. And I do find personally that even when we're not able to minimize the clicks to the point that everyone's thrilled by it, there is significant buy-in when there's that shared understanding of what the goal is, the end goal. And it's not data creation for data's sake, it's data creation for the purpose of driving quality improvement, from improving patient care, from ensuring that we deliver the right care to the right patient at the right time, and even side effects like we can link patients to the appropriate clinical trials and be on the forefront of emerging technologies within medicine. I think those things are really exciting to clinicians, and linking what they're doing in their EMR on a daily basis to those broader shared goals is a way to circumvent some of that increased burden. But I do think AI is going to solve everything for us in this space. To Mike's point, I do envision a world in which I don't spend 30 minutes digging through a chart before I see a patient, but there's a really nice summary. And, Darek alluded to this as well, that sometimes we don't even know the data point we're looking for. So if I may, I don't know, maybe I'm running the clock too much, but COVID, I did this work on long-term care COVID delivery and care planning. And the thing I cared most about was the functional assessment by the OT on the floor. That's not something I usually would care about. Like, a patient summary wouldn't necessarily have that, but it was everything to me in that moment to contextualize these conversations. So having tools that allow me to find that information on the fly to define what's important to me today in this clinical context, I actually think is going to transform care.
Well, thank you so much, Ashley. We don't have enough time, but I think you hit the nail on the head. At the end of the day, like, we're doing it for the patient. We want them to see those quality improvements there. But so big thank you and big shout out to Darek, Ashley, and Mike for coming today and chatting with us about this important conversation. Next up, we have our Infoway's Partnership Conference, November 17th and 18th in Quebec City. And in January, the finale of this series, Projectathons. So thank you so much, folks, and really looking forward to seeing you next time.